welcome to the deep dive. Today we're tackling atrial septal defect, or ASD.
That's right.
Think of this as your express route to understanding this heart condition, what it is, why it happens, and, well, why it matters.
Exactly. We got some really focused notes here. It gives us a clear shot at the essentials of ASD. Our goal is basically to pull out that key knowledge so you can feel confident whether you're reviewing for exams or, just want to get a solid handle on it without getting totally lost in the weeds.
Right. And speaking of things you might not realize, patent foramen ovale, PFO, which is a kind of ASD, is surprisingly common in adults.
It really is.
We're talking somewhere between, 15 and 35% of people. And what's really interesting is that most of the time, it doesn't cause any trouble at all.
It definitely highlights how different these heart variations can be. So in this deep dive, we're going to cover all the crucial angles, what actually defines an ASD, what can lead to it, who is more at risk.
How it affects the body.
Yeah, how it messes with the body's plumbing, what else it might look like, the differentials, who it tends to affect, how it shows up clinically.
How doctors figure it out.
How it's diagnosed, the ways to manage it, what the future holds prognosis, and any potential bumps in the road, the complications. A complete picture, really.
Okay, let's get right to it then. What exactly is an atrial septal defect?
So, simply put, ASD is a heart condition you're born with, a congenital thing. The key point is a hole in the wall, the atrial septum, that divides the two upper chambers of your heart, the atria.
Right.
And this opening lets oxygen-rich blood from the left atrium mix with oxygen-poor blood in the right atrium.
Okay, so what's the reason behind this hole being there in the first place? What causes it?
Well, these defects happen when the wall between the atria, or maybe the connections of the veins to the atria, just don't form quite correctly while a baby is developing during pregnancy.
We touched on patent foramen ovale, the PFO, earlier. How does that fit in?
Yes. So the foramen ovale is actually a normal little flap-like opening between the atria in a fetus. It's there for a reason, lets blood bypass the lungs before birth.
Okay.
In most people, about 75%, this closes up shortly after birth. If it doesn't seal completely, that's what we call a patent foramen ovale, or PFO. So it's kind of like a little leftover tunnel from fetal circulation.
And you mentioned this leftover bit can sometimes cause issues, even if it's often silent.
That's right. Yeah, while it often causes zero symptoms, a PFO has been linked to a slightly higher chance of certain problems in some people. Things like migraines, certain types of stroke, or even decompression sickness, in divers.
Interesting.
It does raise that interesting question about seemingly minor anatomical differences having, potentially unexpected consequences down the line.
So the atrial septum isn't just a solid wall that's there from day one of development.
Not quite, no. It develops in stages. Normally, there's a part of the atrial septum called the fossa ovalis, and that forms where two specific structures, the septum secundum and the septum primum, come together and fuse up.
Okay, so the different kinds of ASDs depend on where exactly this development might sort of go off plan?
Precisely. Yeah, we can categorize these openings between the atria into a few main types. First, there's the patent foramen ovale, that little flap we just talked about. Then the most common type, making up maybe half to two-thirds of all ASDs, is the secundum ASD.
Yeah.
This one occurs right in that area, the fossa ovalis.
Okay, the most common one. And the other types?
Well, there are primum ASDs. They're another version accounting for around 15% of ASDs. These are a bit lower down in the atrial septum and are actually considered part of a broader group of heart issues called atrioventricular septal defects.
Right.
Then we have sinus venosus defects. These involve the tissue near where the pulmonary veins, the ones from the lungs, connect to the left atrium, and also near where the superior vena cava, the big vein from the upper body, connects to the right atrium.
Okay.
And finally, there are coronary sinus defects. These happen when the tissue that should separate the coronary sinus, that's a vein draining blood from the heart muscle itself from the left atrium, doesn't form completely.
Got it. So a few different ways that hole can end up being there. Let's talk etiology then. What fundamentally causes ASD?
So the main reason is that the baby's heart doesn't develop quite normally during pregnancy. But, pinpointing the exact cause is often tricky. It's generally thought to be a mix. Genetics and environmental factors likely interacting.
So genetics definitely play a role.
Oh, definitely. We know that some genetic conditions, like Down syndrome, for example, significantly increase the likelihood of a child being born with an ASD. And also, there are families where secundum ASDs seem to run, which really suggests an inherited component. These familial cases are often autosomal dominant.
Autosomal dominant. Can you give us a quick memory aid for that?
Sure. Think A for affected parent can pass it on, and dominant meaning you only need one copy of the altered gene to potentially have the condition.
Okay, A for affected, dominant for one copy. Got it. Are there specific genetic syndromes strongly linked to ASDs?
Yes, absolutely. ASDs are frequently seen in several genetic syndromes. You've got Holt-Oram syndrome, maybe think H for heart and hand issues, as it often involves both.
Heart and hand, okay.
Then there's Noonan syndrome and Ellis-van Creveld syndrome. And remember, both secundum and primum types of ASDs are more common in individuals with Down syndrome.
You also mentioned environmental factors. What sort of things are we talking about there?
Yeah, certain things during pregnancy have been suggested as potentially increasing the risk. These include fetal alcohol syndrome, maternal smoking, especially in the first trimester, that critical period of development, and also if the mother has diabetes. Now, these are associations, it's important to say. It's not always a direct, cause and effect relationship proven in every case.
Okay, so a combination of our biological blueprint and what happens during pregnancy.
Yeah.
What about specific risk factors, then, that might make it more likely for a child to have an ASD?
Right. The key risk factors we know about are having a family history of congenital heart defects in general.
Okay.
The presence of those genetic syndromes we mentioned, like Down syndrome in the baby, if the mother was exposed to certain medications or substances while pregnant,
right,
and also if the mother had certain infections like rubella, particularly, again, in that crucial first trimester when the baby's heart is forming.
Right. So if there's a hole between the atria, what does that actually do inside the body? Let's talk pathophysiology. How does it affect the heart and blood flow?
Okay, the main thing to grasp is the hemodynamics, basically, how the blood moves, because the pressure in the left atrium is normally a bit higher than in the right atrium.
Makes sense, pumping to the whole body versus just the lungs.
Exactly. So an ASD creates what we call a left to right shunt. You can imagine it like a small detour where some of that oxygen-rich blood from the left side flows back over into the right side, mixing with the oxygen-poor blood.
So the right side of the heart ends up with more blood to pump than it's supposed to.
Precisely. And this extra blood volume and the slightly higher pressure in the right atrium and then the right ventricle can cause these chambers to enlarge over time. They're working harder.
Okay.
And because of this extra blood on the right side, there's also increased blood flow going out to the lungs.
And what are the long-term consequences of this extra workload for the heart and lungs?
Well, if a significant ASD is left untreated for a long time, that increased blood flow to the lungs can potentially lead to pulmonary hypertension.
High blood pressure in the lungs.
Exactly, high blood pressure in the blood vessels of the lungs. And the enlargement of the right heart chambers can eventually lead to right-sided heart failure. So, it's not always just a tiny, insignificant hole. It can definitely set off a chain of events.
That makes sense. Now, when a doctor is looking at someone with possible heart problems, what other conditions might present with similar signs to an ASD?
Yeah.
What's on the differential diagnosis list?
Yeah, it's really important to consider other heart conditions that can have overlapping features. These would include things like a ventricular septal defect or VSD, that's a hole between the lower chambers, the ventricles.
Okay.
Patent ductus arteriosus, or PDA, that's where a blood vessel connecting the aorta and pulmonary artery, which should close after birth, stays open. And atrioventricular septal defect, or AVSD, that involves defects kind of in the center of the heart affecting potentially all four chambers and the valves in between. More complex.
Are there any non-serious things that could potentially be mistaken for an ASD sound, like a murmur?
Yes, absolutely, and this is crucial. It's vital to differentiate ASDs from innocent murmurs. Many, many children have heart murmurs that are perfectly normal, just the sound of blood flowing, and don't indicate any underlying heart problem at all.
Right.
That's why a thorough checkup by someone experienced is so important. Also, pulmonary stenosis, which is a narrowing of the valve controlling blood flow from the right ventricle to the lungs, can sometimes cause a murmur that might, sound a bit similar initially.
That's good to know. So how common is ASD overall? Let's look at the epidemiology.
Overall, the estimate is around 1 in every 1,500 babies is born with an atrial septal defect.
1 in 1,500. And how does that stack up against other congenital heart conditions?
Well, while that's a significant number, ASD actually accounts for less than 1% of all congenital heart disease cases diagnosed. However, and this is important, the true number might be a bit higher.
Why is that?
Because some people with very small or asymptomatic ASDs, especially PFOs, might just never get diagnosed and live their whole lives without knowing.
Right. Still, it sounds like it's definitely one of the more common heart defects we see.
It is, yeah. In fact, it's generally considered the third most common type of congenital heart disease overall.
Third most common.
And interestingly, there's also a bit of a gender difference. Secundum ASDs, that most frequent kind we talked about, they're actually more common in girls, with roughly a 2-to-1 female-to-male ratio.
Huh, interesting. 2-to-1 for secundum. Now, how does ASD actually show up in people? What are the clinical features we might see or hear?
How an ASD presents can really vary quite a bit. It depends a lot on how old the person is and, critically, how big the hole is, how much shunting is happening. Many kids with ASDs, especially if the hole is small, honestly don't have any symptoms at all. They're completely asymptomatic.
So they could potentially go through their entire childhood without anyone knowing.
Exactly. Happens all the time. However, some infants, particularly those with larger shunts, might show signs. They might breathe faster than normal. That's tachypnoea.
Okay.
They might not gain weight well, sometimes called failure to thrive, partly because they're just using more energy with the inefficient circulation. They might seem to get chest infections more often than other kids.
What about when people get older? How might an undiagnosed ASD present itself in adulthood?
In adults, symptoms are definitely more likely to develop, especially if the ASD wasn't picked up in childhood or if it's a larger defect that's been there a while.
Right.
These can include things like feeling tired easily, fatigue, getting out of breath more quickly during exercise, so exercise intolerance, heart palpitations, feeling the heart flutter or race, fainting spells, syncope, shortness of breath, and sometimes swelling in the ankles and legs, peripheral edema. In more advanced cases, particularly if that pulmonary hypertension, the high lung pressure, has developed, adults might experience issues with blood clots traveling where they shouldn't, thromboembolic manifestations, and even a bluish tinge to the skin due to low oxygen, which is cyanosis.
You also mentioned something about irregular heartbeats being more common in adults.
Yes, that's a key point for adults. The risk of developing arrhythmias, particularly atrial flutter and atrial fibrillation, definitely goes up as people with ASDs get older, especially after age 40 or so.
Right.
And also, while pulmonary hypertension is uncommon in children with ASDs, it can develop over time in adults if they have large, untreated holes.
And what about physical signs? What might a doctor find during an examination, maybe listening to the heart?
Well, in babies and children with ASDs, as we said, they often look healthy and pink, especially if the shunt isn't huge. The really key findings often come from listening to the heart with a stethoscope auscultation. The absolute classic sign of an ASD is a widely split second heart sound. It sounds like the second heart sound, the dub of lub-dub, is split into two distinct components, and the split doesn't vary much with breathing. That's a really important clue to remember.
Widely split as two. Got it.
You might also hear a soft systolic ejection murmur. That's the sound of the extra blood flowing across the pulmonary valve into the lungs. And sometimes, especially with bigger shunts, you might hear a diastolic rumble, which is due to increased flow across the tricuspid valve on the right side.
So that widely split second heart sound is the big flag for revision.
It really is. While these classic sounds are maybe more obvious in adults with significant shunts, they can certainly be present in children too. Now, signs of actual right heart failure, like an enlarged liver or swollen neck veins, those are pretty rare in children with isolated ASDs, but can definitely occur in adults if they've developed significant pulmonary hypertension.
We had a quick note about Ebstein's anomaly in our source info. How does that compare in terms of how it shows up clinically? Just briefly.
Right, Ebstein's is quite different. It affects the tricuspid valve, the one between the right atrium and right ventricle, and the right ventricle itself. How it presents can vary a lot, from very mild to very severe. Symptoms can include cyanosis, that bluish skin color, fatigue, shortness of breath, dyspnoea, palpitations, and in severe cases, sadly, even sudden cardiac death. Physical signs can include that cyanosis, maybe clubbing of the fingers and toes. Sometimes the chest might look a bit uneven. There might be signs of fluid buildup. And the heart sounds and murmurs you hear are distinct from a typical ASD. It's a different kettle of fish, really.
Okay, so distinct sets of clues for different conditions. Now, if a doctor suspects someone might have an ASD based on these features, what kind of tests would they usually order? What are the main investigations?
The number one tool, the primary diagnostic test, is echocardiography.
An echo.
The ultrasound of the heart. Exactly. It uses ultrasound waves to create detailed pictures of the heart. This can be done by placing the probe on the chest, that's transthoracic echo or TTE, or sometimes, for a clearer, more detailed view, especially the back structures like the atria, they might pass a small probe down the esophagus, transesophageal echo, TB.
Okay.
The echo lets doctors actually see the hole directly, measure its size and location precisely, and importantly, assess how it's affecting the heart structure, like chamber size and function. You could maybe think echo helps you see the hole.
Echo to see the hole. So the echo's really key for visualizing the defect. What other tests might provide useful clues?
An electrocardiogram, the ECG, which measures the heart's electrical activity, can also give us helpful pointers. Now, in kids with small shunts, the ECG might actually look completely normal.
Okay.
However, typical findings suggesting an ASD, especially a larger one, can include a tall P wave. This can suggest the right upper chamber, the right atrium is enlarged. Maybe it can P for pressure, building up in the right atrium, making the P wave taller.
P for pressure, good one.
We might also see something called an incomplete right bundle branch block pattern. This reflects a slight delay in electrical conduction through the right ventricle because of the extra volume. So maybe remember RBBB for a right-sided electrical delay pattern.
RBBB for right-sided delay. Okay.
And sometimes the overall electrical axis of the heart might be shifted towards the right side, which we call right axis deviation.
And what about a simple chest X-ray? What might that show?
Again, in cases with small shunts, the chest X-ray or CXR might also look normal, nothing obvious.
Right.
However, in more significant ASDs, we might see cardiomegaly. That means the heart shadow looks enlarged on the X-ray, particularly involving the right atrium and right ventricle. We might also see the main pulmonary artery segment looking prominent, and the blood vessels out in the lungs might look more prominent too, increased pulmonary vascular markings, indicating that increased blood flow.
Are there any more specialized imaging tests that might be used sometimes?
Yes, cardiac MRI or CMR can be very useful. It gives really excellent detailed pictures of the heart's anatomy and can quantify the blood flow across the shunt very accurately. It's particularly helpful for those less common sinus venous defects, which can be harder to see well in echo sometimes.
Okay.
Cardiac CT scans are another option that provide great anatomical detail, but they aren't used as often for the initial diagnosis, mainly because of the radiation exposure, especially in children.
And what about cardiac catheterization, where they actually thread a thin tube, a catheter, into the heart? Is that still used much for diagnosis?
Cardiac cath isn't typically the first-line test for diagnosing ASDs anymore. Echocardiography and MRI are usually so good now.
Right.
However, it might still be indicated in specific situations. For example, if there's concern about high blood pressure in the lungs, pulmonary hypertension, because cath can directly measure the pressures inside the heart and lung arteries. Or in adults who might also be at risk of coronary artery disease, the cath can assess the coronary arteries at the same time.
Okay. And just to quickly loop back to Ebstein's anomaly, were there any specific investigation findings mentioned for that in our notes?
Yes, quickly. In Ebstein's, the ECG changes are often quite striking and characteristic. They can include tall and wide P waves, often a complete right bundle branch block, and typically small R waves in the ECG leads looking at the front of the heart, like V1 and V2.
Okay.
Also, sometimes electrophysiology studies, EP studies might be needed. These involve catheters with electrodes to map the heart's electrical system, particularly looking for any extra electrical pathways, often on the right side, which can predispose people with Ebstein's to certain arrhythmias.
Okay, so we've investigated, we've confirmed someone has an ASD. What are the options for managing it? How do we approach treatment?
Right. Management really depends on several factors. The size of the ASD, whether it's causing symptoms or affecting the heart size, the specific type of ASD, and the person's age and overall health. Let's start with general medical care first.
Okay.
For comparison with Ebstein's anomaly, medical management focuses on things like antibiotic prophylaxis to prevent infective endocarditis in certain high-risk situations and managing any heart failure or arrhythmias that might develop using medications.
And what about for kids who just have a standard ASD? What's the usual medical approach?
For most children with ASDs, especially secundum ASDs, they generally don't need to restrict their physical activity. They can run around and play normally. And importantly, routine antibiotics just to prevent heart infections, endocarditis prophylaxis, are not usually recommended for simple, isolated ASDs anymore.
Okay, good to know.
If there happen to be signs of heart failure, which is uncommon in kids with ASDs but possible with very large shunts, they might need medications like diuretics to help manage fluid buildup.
And what about adults who perhaps get diagnosed with an ASD later in life?
Adults who find out they have an ASD later on might also need medical treatment, particularly if heart failure or arrhythmias like atrial fibrillation have developed as a consequence of the long-standing shunt.
Now, what about actually fixing the hole itself? What are the options for closure, like surgery?
Surgical repair is generally recommended for significant ASDs, meaning those that are causing symptoms, or have led to enlargement of the right side of the heart, or have a large amount of blood shunting across, usually defined by something called a QP-Qs ratio.
Okay.
Typically, if surgery is needed for ASDs found in childhood, it's often electively done around 4 to 5 years of age before starting school.
Right.
The standard procedure usually involves open heart surgery using cardiopulmonary bypass. The heart-lung machine temporarily takes over, allowing the surgeon to directly see and close the hole, often with a patch. In some centers, less invasive video-assisted surgical approaches might be an option for certain ASD types.
And I know there's also a less invasive way to close some ASDs now, going through the blood vessels with a catheter. How does that work?
Yes, transcatheter closure has become a really important alternative to surgery for specific types of ASDs, most commonly the secundum type. It's not suitable for every ASD. The hole needs to be in the right location, not too large, and have sufficient rims of tissue around it for the device to anchor securely. But for suitable defects, the procedure involves guiding a catheter, usually inserted through a vein in the leg, up to the heart. Then a special closure device, often designed like 2 small umbrellas or discs connected by a waist, is deployed across the hole, effectively plugging it from both sides. It generally has very high success rates, over 95%, and low complication rates.
Wow, that sounds much less invasive.
It is, and another benefit is, similar to surgical repair of simple ASDs, after successful transcatheter closure, routine endocarditis prophylaxis, those antibiotics are generally not needed long-term.
Okay. And just a quick reminder on managing Epstein's surgically if needed.
Right. Managing Epstein's surgically is often more complex and definitely tailored to the individual anatomy. If intervention is needed, repairing the abnormal tricuspid valve is generally the preferred approach when possible, rather than replacing it. For very severe cases in newborns, sometimes palliative procedures are needed initially, and in select older patients with severe symptoms or heart failure, heart transplantation might eventually be considered. But the key takeaway for both ASD and Epstein's is that the management plan is very personalized.
Okay, so looking ahead, what can people generally expect in the long run? What's the prognosis for someone diagnosed with an ASD?
The long-term outlook, the prognosis, really depends on a few key things. Obviously, the size of the defect is important. Also, if there is any significant leaking of the tricuspid valve, which can sometimes be associated particularly with primum ASDs, the degree of heart failure, if any, develops, whether there are other associated heart problems, and importantly, whether any significant arrhythmias develop. Generally speaking, adults who have smaller ASDs, perhaps diagnosed later in life without major complications having developed, tend to have a better long-term outlook compared to those with very large defects present from birth.
What about the outlook if a significant ASD isn't treated?
Historically, before effective closure techniques were widely available, if a significant ASD wasn't closed, the data suggested that fewer than 5% of people lived beyond 50 years old due to complications like heart failure and pulmonary hypertension.
Wow, that's quite stark.
It is. But the good news is that repairing the ASD, whether surgically or via catheter, significantly improves prognosis. It reduces morbidity, illness, and mortality, and it improves symptoms and exercise capacity. And importantly, studies show these benefits occur even if the repair is done later in life, say after age 40.
That's really positive.
It is. However, one important caveat is that even after a successful ASD repair, there remains a persistent, slightly increased lifetime risk of developing atrial flutter or atrial fibrillation compared to the general population. It doesn't completely eliminate that risk.
Okay, something to be aware of long term. And for Epstein's anomaly, what was the note on prognosis?
For Epstein's, unfortunately, the prognosis for babies and newborns who present with severe symptoms can be quite poor. For milder forms diagnosed later, the outlook is much more variable.
So early detection and the right treatment, especially for significant ASDs, really can make a huge difference to the long-term outcome. Finally, let's quickly summarize the potential problems or complications that can arise from an ASD, especially if it's untreated or if issues develop down the line.
Sure. The main potential complications of an ASD include pulmonary hypertension, that high blood pressure in the lung arteries we've mentioned, caused by the long-term extra blood flow.
Okay.
Atrial arrhythmias, especially atrial fibrillation and atrial flutter, particularly in adults.
Right.
Paradoxical embolism, this is a potentially serious one where a blood clot that forms in a vein, maybe in the legs, can travel through the ASD hole across to the arterial side of the circulation and potentially cause a stroke or block an artery elsewhere. Infective endocarditis, an infection of the heart lining or valves. This is actually a relatively uncommon complication in simple isolated secundum ASDs, but the risk might be slightly higher with other types or if there are associated valve issues.
And lastly?
And lastly, right-sided heart failure. This can develop over many years due to the chronic volume overload on the right ventricle from a long-standing, significant shunt.
Okay, so quite a few potential issues to be aware of. To wrap it all up then, atrial septal defect is a congenital heart condition, basically a hole between the upper heart chambers. How it presents and how it's treated can vary a whole lot depending on the specifics of the defect, the size, the type, the person's age, which really highlights why early diagnosis and getting the right intervention at the right time are so crucial.
That's a great way to summarize it. And, it really makes you think about how even seemingly small structural differences that we're born with can potentially have quite significant effects on our cardiovascular health much later in life. It kind of begs the question, what other seemingly silent or minor conditions might have similar long-term impacts that maybe we're still only beginning to fully understand?
Definitely something to ponder. For those of you listening who want to delve deeper into this or need more resources for revision, especially for exams like the MSRA, be sure to check out pathophysiology.com and also freemsra.com for loads of useful material.
Great resources.
Thanks everyone for joining us for this deep dive into atrial septal defect.